Hi, my name is Carly, and this is my case study number 2. So we have a 50-year-old female with complaints of epigastric pain, fever, statorrhea, anorexia, nausea, vomiting, diarrhea, times 1 week. So the 50-year-old female is presenting today with complaints of severe epigastric abdominal pain that radiates to her back with associated nausea, vomiting, diarrhea. She also has fever, anorexia, tachycardia, and statorrhea, times 1 week. The patient states that the pain began after eating a burrito and her pain has steadily increased over the past few days. She describes the pain as burning and achy, worse with lying flat after eating and drinking alcohol. Her pain is currently 10 out of 10. She has tried taking Tylenol and ibuprofen without relief. She states that the pain is only slightly relieved after sitting or standing up. Her last drink of vodka was this morning at 7 a.m. with subsequent nausea and vomiting and an increase in her pain severity. So her past medical history, she has hypertension, hyperlipidemia, GERD, depression. She was treated for H. pylori in 2010, and she gets ETOH withdrawal seizures. She drinks 1 liter of vodka per day. She smokes 1 pack of cigarettes per day. She denies illicit drug use, no known drug allergies, and denies environmental allergies. She's up to date on her childhood vaccines, but no recent Tdap or flu vaccine. Past surgical history is a hysterectomy in 2016 and then a skin cancer removal on her right shoulder. She is currently homeless and living out of her car. She denies having medical insurance. She uses her EBT card to access food, but says that she eats a diet high in fats and carbohydrates. She does not take medication because she cannot afford them. Her mother died of a heart attack at 60 years old. She also had hypertension and hyperlipidemia. She never knew her father. Her brother died at 23 years old of an opiate overdose. Her maternal grandmother is alive. She's 80 years old and has hypertension, hyperlipidemia, diabetes, and alcoholism as well. Her maternal grandfather died at 59 of a stroke. He also had hypertension and hyperlipidemia. So my review of systems. So my patient is endorsing fever, chills, and recent weight loss of approximately 10 pounds over the last week since falling ill. She has a new onset of jaundice with complaints of generalized pruritus and diaphoresis. She endorses a headache of 5 out of 10 and feels dizzy when she stands up. She complains of a burning, stabbing pain to her epigastrium radiating to her back, but denies radiation into her neck or arms and denies any palpitations. She complains of shortness of breath, but denies any cough or recent upper respiratory infection. Endorses severe burning, achy abdominal pain that radiates to her back with tenderness to her epigastrium. She complains of bloating and anorexia. She endorses frequent loose stool that is light in color with a greasy appearance. Endorses continued alcohol ingestion causing increase in pain and then subsequent nausea, vomiting immediately after. She endorses feeling dizzy, fatigued, and tremulous, and she also endorses severe anxiety related to her pain, and she hasn't had alcohol in a couple of hours. So current vital signs are temp of 101, blood pressure 175 over 92, she's tachy at 112, respirations are 23, 97% on room air with pain currently at 10 out of 10. She's a morbidly obese, toxic appearing female. She answers questions appropriately but appears disheveled and is writhing in pain during my assessment. Scleral icterus is noted bilaterally. Her optic disc margins are sharp, but there are bilateral superficial retinal hemorrhages noted. She is tachypnic, but speaking in full sentences. Her breath sounds are auscultated in all lobes, but she does have diminished bases. S1, S2, no murmurs, no gallops, sinus tach without ectopy or ST changes on her EKG. PMI is non-displaced, midclavicular, brisk and tapping at 2.5 centimeters. Pulses are 3+ and palpable, no bruit, no thrill, no edema. Abdomen is distended and firm with guarding and tenderness to the epigastrium. Noted statorrhea with excess flatulence. No palpable masses. Liver is non-palpable. Spleen is non-palpable. Bowel signs are hypoactive in all 4 quadrants. No bruit noted to the aortic, iliac, renal, or femoral arteries. No suprapubic pain or tenderness, but she does have tea-colored urine. Generalized jaundice and pruritus is noted to her skin with tar staining to her first and second fingers. She moves all of her extremities. She's alert and oriented ×4. Her cranial nerves are intact. She answers questions appropriately, but she's anxious and having difficulty participating in the exam due to her pain. So my primary diagnosis is alcoholic pancreatitis with respiratory complications. Alcoholism and smoking is a big trigger for pancreatitis, and with her shortness of breath, I would want to rule out any complications such as ARDS. I also want to rule out biliary obstruction. Pancreatitis can come from a blockage in the common bile duct or the biliary tree. I want to rule out MI. Her mother died of a heart attack, and also epigastric pain can be a sign of an MI, particularly in females. She described her pain as acute after eating a burrito, so I would want to rule out gastric ulcers as well. She did have H. pylori in the past, which can cause gastric ulcers. I also want to rule out pancreatic or GI malignancy. She's having nausea, vomiting, diarrhea, severe pain, and fever and weight loss, so that would be important to rule out. And then also a dissecting aortic aneurysm. It can be described as epigastric and radiating to the back, so that's a big one I wouldn't want to miss. Some of the labs, tests, and treatments I would do is CBC, CMP, lipase, amylase, bilirubin, CRP, a lipid panel, coagulation studies, an alcohol level, and a troponin. I'd want to do an AVG because, again, I'm ruling out ARDS, respiratory complications. I want to look and see how she's oxygenating. A chest x-ray to look at her lungs, a transabdominal ultrasound to look at the biliary tree, the bile ducts, look for any sort of gallstones. And then I can do a CT of her abdomen as well. I would want to keep her NPO and start Ringer's lactate, give her IV pain medications such as morphine and benzodiazepines for her ETOH withdrawal. I also want to monitor her blood glucose and rest her bowels, and also she will be admitted to the hospital. So pancreatitis. So it's an acute inflammation of the pancreas that can be caused by a couple things, such as biliary disease like gallstones, alcoholism, or infection. So the pancreas is responsible for releasing proteolytic enzymes for digestion into the small intestine and for hormonal glycemic control with the use of glucose and insulin that's released into the bloodstream. So the inflammation from pancreatitis causes a premature release of these digestive enzymes from the pancreas, which would normally be released into the small intestine to help with digestion. But these enzymes are activated prematurely and they begin to digest the pancreas and the surrounding tissues, which causes the pain and inflammation. So typical signs and symptoms are severe epigastric pain that radiates to the back, jaundice because you're blocking that bile duct, hyperglycemia, steatorrhea, hypotension, colon sign, which is ecchymosis around the belly button, or Turner sign, which is ecchymosis to the flanks, respiratory distress, and a rigid abdomen with tenderness and guarding. So this patient is particularly at risk for sepsis, necrosis of the pancreas, ARDS, electrolyte imbalances, and then organ failure. Here are my references, and thank you guys so much.